Good evening, everyone. For those of you who I have not had the pleasure of meeting by Zoom, I am Twyla Dependahl, Executive Director for our local Nami affiliate. I am excited to kick off this evening's event. We have an illustrious group of presenters who will share what we anticipate with the implementation of 988 and the pilot program, Community Wellness and Crisis Response Team. At 8:20, we will have Kate Phillips, one of our board of directors, who will share about our upcoming walk, our largest annual fundraiser. Yeah, as you can see, Christina has her virtual background. Nami walks your way. Yay. Speaking of fundraisers, as part of our May Mental Health Awareness Month, we conducted a mailing campaign to increase donations and memberships. I am thrilled to say that due to this effort, we brought in a little over 8,000 and increased our membership by 100 in the short few months. We are now over 200 strong. So thank you to those who are members, those who became members due to this campaign. And if you're not a member, sign up tonight. Spread the word, as we cannot do this work without the financial support of our community. The more members we have, the stronger our voice is at the national level. A lot of time and effort has been spent to get us to this point. William will be sharing more on this. With William's leadership, he was the author of the article with a few of us as editors that was featured in our spring newsletter and now found on our website under newsletters and our very new reimagined crisis response page. Thank you, Christina, for that effort. William did a lot of the legwork. He interviewed folks, researched current agencies and their service models, found out what was happening during a mental health crisis in our community. So I want to be sure he gets the recognition he deserves. Okay, William, our moderator, take it away.
Well, I'd say panelist, but hi, my name is William Elting, and I'm really glad to be here tonight. I just want to point out that it is Suicide Prevention Month. And, you know, I can't think of a topic more relevant to suicide prevention than crisis response. So I really think it's great timing that we're here and get to start this month off with such a big event. And I'm just delighted at how many people have signed up to come to this. I really think there's going to be a lot of great information that comes out tonight. And I think it will end a few conversations, and I think it'll start many, many more. So I'm a longtime San Mateo County resident, and I've been active in the mental health community for about 4 years. I'm a suicide crisis line telephone counselor in StarVista's Crisis Center, and I speak against mental health stigma for the Heart and Soul Seeing Through Stigma program. I also do talks around the county as part of the Behavioral Health and Recovery Services Lived Experience Academy. But I'm here tonight as a member of NAMI San Mateo, where I'm a board member, a warm line operator and the trainer, a connections facilitator, and most importantly tonight, a member of the Reimagining Crisis Response Work Group. The work group grew out of a partnership between NAMI San Mateo and the Sheriff's Department in helping to deliver the Crisis Intervention Team, or CIT, trainings. Emily Chandler handled this all by herself for NAMI San Mateo for years, and I'd be remiss not to thank her for all that work. Ruanne Fournette has capably taken over that CIT piece, and we're very fortunate to have her doing that. And the work group has expanded and now includes the board secretary, Liz Downard, Randy Hutchinson, our newest member, Ellen Darnell, and of course, executive director, Twyla. So what we hope to accomplish tonight? Well, it's fair to say that San Mateo County is behind the curve in implementing changes in mental health emergency responses. The good news is this means that we're not trailblazing. You know, for example, there's a model in Southern Arizona that's getting a lot of attention. It has a 5-tier dispatch system where calls are handled by crisis counselors, and the tiers range from the lowest level being that it can be handled by phone to a clinical response, and finally to a law enforcement response. So there's really a lot of different things that they're doing there to actually make that initial response to the call. They also have a huge facility that's staffed 24/7 that includes clinical people, social workers, peer counselors, and it takes anyone, no matter what condition they're in. They don't turn anyone away. And they have what's called a no wrong door policy for the police, which means that it makes their jobs easier because they can just bring them to this place and bring people to this place and drop them off. And there's no time lost. There's no, you got to take them somewhere else or put them in an ambulance or whatever. And I've asked that the link to a webinar about this be put in the chat. If you fast forward to about 40 minutes in, you'll see them talking about the Southern Arizona model. Before that, they talk about a Georgia model that's also pretty good and way ahead of where we are. There's also a document now called the Roadmap to the Ideal Crisis System. And this is it. You know, and the good news is that there is a document out there now that is basically talking about best practices for how to do this. It's 209 pages long, and I'll admit I haven't read the whole thing. I did go to a webinar on it, but I do want to point to one thing here on page 177. And it is 10 steps for communities. So step one, identify and convene community partners. Identify community stakeholders and potential partners who are interested in or have a stake in behavioral health crisis services within your community and develop a voluntary ad hoc group for initial discussions. Well, that might be where we are, right here at step one. And, you know, I'm hoping that that's what we accomplish tonight and it can help launch us along this path. So the partners in the process tonight are Nami San Mateo, StarVista, and the county's behavioral health and recovery services. And I'm going to let the panelists introduce themselves and talk about their roles a little bit later. But first, a little bit about each of our organizations. This presentation is being brought to you by Nami San Mateo. And Nami San Mateo is the county's affiliate of the National Alliance on Mental Illness that has state and local affiliates that are generally done by county. We are dedicated to improving the quality of life for people with mental illness and their families through support, education, and advocacy. Our roots are in supporting family members of people with mental health challenges, and we're still the premier organization in the county when it comes to providing this service. And this is why this issue is so important to us. It's often our members who have to make that call when there's a mental health emergency. And this is something that's very important to us, and that we take that service very seriously. I often call StarVista the best kept secret in the county. They run the crisis center, which includes the local suicide crisis hotline, the text line, and the school intervention program, among other things. StarVista also has many other programs that are just amazing and incredibly relevant. They run the sobering station, and with the Palm Avenue detox closed, it's a good thing we have that sobering station right now. They run Your House South, which is a respite home for youth. They run the Pride Center, which is a fantastic resource for the LGBTQ plus community. And we get so much good feedback about everybody we send there. They have a counseling center where someone can actually get an appointment. They have mandatory offender programs for people who've come out of jail and need to take classes or do things like that. They have a program that provides counselors in school, mental health counselors, not guidance counselors, and much more. You know, if the roots for a Southern Arizona type system are anywhere in San Mateo, they're in StarVista. And then we have BHRS. They're the county's presence in the mental health and recovery world. And they are a robust and many-faceted operation under the direction of Scott Gilman. They oversee the clinical side of the existing programs for mental health emergency responses like Pert and SMART. And they're in an oversight capacity in the new endeavors like the pilot programs, which will be discussed later. So what are we doing at Nami San Mateo? Well, awareness is an important thing for us. It helps with planning and it helps with expectations. It came to our attention several months ago that law enforcement procedures around mental health emergency responses had changed. And months of researching this resulted in the article, Reimagining Mental Health Emergency Response, in the Nami San Mateo Summer Newsletter. And we'll put a link to that in the chat, but I'm really hoping that most of you here had a chance to read that because we're not going to go over it in detail, but it does kind of lay the basis and the groundwork for why these alternative responses and these other things that are being done are so important. You know, to summarize, primarily as a result of changes in the law, the police will be taking a different approach to mental health emergencies than they did in the past. They're going to be slowing things down, calling for backup, engaging supervisors, securing scenes. They're not going to be rushing in. And I think, this is probably a good thing for everybody. What is called priority of life is going to be of the most importance. The goal is the safety of everyone, the family, the police, bystanders, as well as the person in crisis. And protection of property is a low priority when you're looking at things in terms of people's lives. We documented this so that our members and others can properly prepare for what may be a different experience when calling 911 than what's happened in the past. We had a meeting of all our public-facing staff and volunteers to debrief and prepare them. Our work group is working hard to prepare brochures and other documents to help with that preparation. And we're going to be modifying our training programs to reflect these changes. We think that if people have realistic expectations when they make that 911 call, it's going to help the people who've made the call, and it's going to help the people who are responding. And knowing what to expect is going to be very important. These changes are a mixed bag in some way, but they have been working out for the most part. And I think everybody agreed that there needed to be changes. And this brings us back to those best practices. There are other ways to respond to mental health emergencies. Systems are in place everywhere. And we have people in this county who are actively working on this. And that brings us to our next panelist. With that, I'm going to turn it over to Zena from the StarVista Crisis Center.
Hey, hello everyone. My name is Zena Andriani. I use she, her pronouns, and I am the program manager of the Crisis Intervention and Suicide Prevention Center with StarVista. I'm happy to be on this panel with some others on my team and others that I work with as well. And today I'm just going to kind of talk to you about the Crisis Center's involvement, and we have a number of different programs. We're one of StarVista's oldest programs. We have our 24/7 crisis line. We're accredited through the American Association of Suicidology, and we do receive calls from the National Lifeline. I am very happy to say that we have been a part of an initial state grant to start planning for the 988 rollout, which will happen in July of 2022. And we do many other things, which Brooke will get to share about as well. We have teen crisis services, both texting services, chat services, and then we have our youth intervention team, which will be expanded to a larger mobile crisis response team as well. So I'll just start out and kind of talk a bit about 988 and how we've been getting ready. So just a brief introduction, because I have a feeling most of you already know this information, but next year the National Lifeline number, the 1-800-273-TALK will change to 988. And all Lifeline centers will be involved in that shift. And so whereas before StarVista and the Crisis Center received all numbers or all phone calls from the National Lifeline with the 650 area code, anytime anyone's dialing 988 with the 65 area code, they'll come to us. And we will continue to do the amazing work that we know we've been doing for a very long time. This is not, this is a long time coming. And so we'll continue to be a support and a safety net for those in distress. And our hope, as always, is to reduce suicide and support through mental health crisis and to have a pathway for well-being. So what we've been up to essentially over the last few months is just to identify all the centers that will be in the state that will be involved in responding to 988 calls. So it's us plus all regional centers. So San Francisco is involved, Contra Costa, for example, any accredited center. And we are just looking at sort of what capacity we're going to need to build out in order to respond to these calls. Other states that have implemented 988 have said that it's about a 30% increase in calls. So many other agencies, as well as ourselves, we're doing as much as possible to try to be prepared for that increase in call and really ready for anyone who's calling. So that's about as far as we've gotten. I know a couple of days ago, the state did issue about $20 million to fund local crisis centers that are seeking to prepare for 988. So we do hope at some point, in some way, shape, or form, to receive those dollars down the road. And again, that will really be focused on building capacity and to have the infrastructure in order to call. Compared to other crisis centers, our center, we always say, is really small and mighty. And so, many, many times there's, maybe one or two people just responding. And so if we looked at a 30% increase in call, we'd really have to just make sure we have enough people to answer those calls. So that's really kind of where we're focused, and really making sure that we have folks that are trained and that our, trauma-informed practices and our integrity stay the same as we continue to expand. And many other centers are also doing the same. So yeah, that's fairly it for 988. We're just sort of planning that way, and really hoping to sort of expand and grow. And then another piece to this is that, which Brooke, I'll pass to you in a second, but we have been actively working on a youth mobile crisis response team. So part of our hope as the Crisis Center is to be sort of a hub and response. So if you call the Crisis Center and you're either needing telephone services or just those response, that you have that interconnected, but that you may also be connected to some of these other crisis response team, including the Youth Mobile Crisis Response and other programs that are doing similar work. So we will continue to be a home, and we will continue to hold, knowledge and appropriate information to be able to pass people to the appropriate parties. Brooke, if you want to talk a little bit about Youth SOS.
I have picked up on those social cues. Thanks, Z. Hi, everyone. Good evening. My name is Brooke Pollard. I use she, her pronouns, and I am the program coordinator for the Youth Stabilization Opportunity and Support Team, or as we at the Crisis Center call it, the Youth SOS Team, to save us the breath, as well as I think most people, when they think of SOS, it's a call for support, right? So we wanted that to be very in line with that and with our program and our mission. So the Youth SOS team will be shortly up and running, and what that will look like is it will look like either over the phone or in-person response to mental health crises for our young people in this county. The limitations, we really tried to work on removing as many barriers to this service as possible. We really like to think that all of our services at our Crisis Center and StarVista as a whole, but specifically at our Crisis Center, are accessible. We don't want there to be a ton of barriers, or you have to go through a core service agency to access us. You can literally access us through our hotline, through our website. And so for this new Youth SOS program, really it's just the person who is experiencing an increase in mental health symptoms or maybe suicidal, homicidal ideation has to be under the age of 25, and they have to be within our county. That's it. Those are the two requirements for this program. And what will happen and how you would access this is through our crisis hotline. So if there is a parent or guardian of someone who's concerned about their child, if it is another provider out in the community that is concerned about a young person, if it is a teacher or a school admin, whoever it is, they can call our line and let us know that they would like some support and specifically for this young person. And then they will be connected through our hotline to the Youth SOS team. Another piece of this SOS team is we will also be part of the Family Urgent Response System. This is also an already existing program and system throughout the state of California that responds very similarly to folks experiencing a mental health emergency or crisis that is either a current or former foster youth. So we will also be taking that on as well. And that is just part of enhancing even more so our crisis care continuum in our county. This team will function as a team, both in our center as well as out in the community. It will be pairs of both a clinician to do the assessment and continue therapy if that is something that is needed for the young person, as well as a family partner. And a family partner is someone who has lived experience, who really will walk alongside the family and focus more on maybe like what the needs of that family system are, so that they can focus and support this young person going through whatever it is that they are going through in that moment. And, you know, we imagine that, again, not up and running, so I don't have all the answers just quite yet, but we imagine that there will also be a continuing of care with the family partners and that family. Let's say, you know, a young person is really worried about food insecurity, and, you know, that is really weighing heavily on that, not only them, but their family. Part of the family partners role will be to kind of, you know, highlight what services in our county offer food support, and maybe link them up and connect them to that type of care as well. So we want to look, we always say that crisis, it's not just the mental health side, right? Like everything is involved in mental health care. If you don't have somewhere to stay, if you don't have somewhere to live safely or food to eat, you're going to be in crisis. And so we really wanted to make sure that we're not just taking care of the mental health side, but we're looking at what other things are at play and how we can support the families and the young people who access this service. So ideally, we have some intended outcomes. Again, this has not started just quite yet, but we have 5 really amazing intended outcomes that we hope to achieve. The first is that we hope to decrease youth psychiatric emergency service visits. As I'm sure a lot of people here know, those visits can oftentimes be more triggering. It can create more mental health distress than even prior to being hospitalized. The second outcome is we hope that it decreases hospitalization for self-inflicted injuries, non-suicidal ones, and or other mental health issues that maybe didn't need to escalate to a hospitalization. The third outcome is that we hope it will also decrease emergency calls to law enforcement for youth in crisis. They have a lot going on, and as William kind of hinted at and wrote a beautiful article about, things are changing in our county. And so we want to be there and step in and support young people so that they still have someone to call when things are getting really hard for them. The fourth is that we hope there are increased linkages for family or children and youth and their caregivers to services. Sometimes, you know, a lot of times, and I'm sure William again can attest to this, people call in our line and they just don't know what's out there. They don't know what supports, incredible supports are in our community. And so we hope to really help bridge that gap to empower folks that they can, you know, call these places on their own if things do escalate again in the future. And then lastly, we also hope to improve the capacity of youth and their family or caregivers to recognize the need for intervention and the ability to seek out those services when needed. We hope that, you know, we provide services in a trauma-informed way and a really mindful way that, you know, people are willing to call us again and recognize that there are options out there for them. They don't have to, you know, handle this, whatever that means, on their own, that there are people in our community that are willing to step up and support them. And so, yeah, I think that's about it. I'm happy to answer any questions if I didn't cover things well enough. But for now, I will just hand it over to Jen.
Hi, good evening, everybody. Thanks for joining us tonight. My name is Jen Bassler. I am the Clinical Services Manager for Behavioral Health and Recovery Services over Crisis and Outreach. And I think I'll start just by saying, you know, one of the changes that has been, the BHRS has made this year is that we have put all of our crisis and outreach under one umbrella. So that meaning that previously you would have, like, say, the Pert team under one thing and SMART under another department, and you know, other all of our programs in different places, but now we have everything under one. So that is a fabulous step. The reason we're doing that is because we want to move to a model of integrating our crisis and outreach teams and better collaboration with our partners and our community partners, you know, all the people that we work with, because I know how difficult it is to understand the system, the acronyms, you know, all the things that get thrown at us. But in particular, to this discussion, I oversee the Psychiatric Emergency Response Team. And that team, I think we've been around for a while now, but I think that some of what they actually do has gotten lost in translation along the way. The Pert team is sheriff's jurisdiction only. So that's the one thing with Pert, why, I get questions like, why can't we call Pert? Well, if you're in San Mateo County, Pert services only sheriff's office jurisdiction. They do crisis response. In fact, the first 2 years I was on the Pert team, and all we did was crisis, like 911 calls from deputies and such. And then when we got a little bit bigger of a team, I now have 2 teams under me for Pert, and they do a lot of consultation with officers over the phone. They do family follow-up. As William has been saying, and as we all know, there's some changes in how law enforcement and mental health are going to interact. And that means that, we're learning ways to slow down, like William said, to slow down the process and, make it safe enough for the clinicians to go in to a scene and a situation where they are better able to handle a person who's in distress or in crisis. The other team, one of the other teams pertinent to this conversation is the SMART team. That stands for San Mateo Assessment and Referral Team, but it's a medic. It's only one medic. There are 2 vans, and they run from 9 in the morning till 10 at night. So that medic has to be CIT trained through the sheriff, and then they get another 40 hours of training from my crisis team. The third one is the pilot program that William mentioned at the beginning as well. And it is community wellness. I have to always say the acronym in my head first. Community Wellness Crisis Response Team. This is a co-response team. Like Pert, who's also a co-response team, that means a co-response team is a team that goes out with police. So both Pert and CWCRT will be going out with police to the tier 1 crises. I think it's really important for the community to understand the different tiers of crises that we're talking about. Not all crises are the same. So if you have someone calling 911 and a person has a weapon and they're a danger to themselves and others, I mean, yes, we're going to send Pert or CWCRT. Once the scene is secure, we can talk about other options, but that is the purpose of them. And I call that, and what other models, and I have read the Ideal Crisis System, William, front to cover, but it's really important to understand that would be for like a tier 1 crisis. BHRS also has different programs that handle tier 2 and tier 3 type crises. So that would be something where you're having, your loved one or someone you're calling about is having a mental health crisis, but you're not in fear for your life. They're not committing a crime. You've been in this boat before, let's say. And so I have different teams and different people that can be sent out to talk to those during that crisis. So I think, part of our work in the work group is defining the different crises and what the different programs do for each crisis. We partner very closely with StarVista. We are the contract monitor for Youth SOS and FERS, which is the same thing, but Youth SOS with the FERS component. And we also contract with StarVista for the CWCRT new police pilot program. I think that's all I have to say, because I'm sure there's going to be a lot of questions. And so I don't want to confuse with all the rest of the programs. We are working on, homeless programs for the homeless and other people that are also in crisis, but not necessarily a 911 crisis call. Thank you.
Okay, so I just wanted to kind of clarify, the CWCRT is in the planning stages and not up and running yet. And as I hear it, right now in the process of hiring the clinicians that would be out there, working with the police. Is that right?
Correct. Yeah, we have all the program components are in place. The policies and procedures are in place. How we're going to train these clinicians are going to get trained with myself and my team. The police training is all in place. It's already, California is having a really difficult time hiring clinicians right now. And particularly, it's not a brand new field, but it's it is a relatively new field and what we're going into now as a country when we're talking about mental illness and police and how we deal with things. So that's the biggest challenge that we have with that program at the moment. And in case I didn't mention it, and I apologize, it will operate similarly to Pert. So Pert, Psychiatric Emergency Response Team, Sheriff's Jurisdiction, the same clinician rides with the same detective every single day. With CWCRT, the clinicians will be out on the street, they'll have a police radio, they'll be able to be called by dispatch or by other deputies. And if they're called to the scene, they'll go to the scene, and what they do is they'll stage, what they call staging. And then when the police say it's fine to go in, everything's safe, then they'll go in, right? So they'll be roaming more in different cities to be able to get to places a little faster.
Okay. But initially it's 4 cities to start?
4 cities in the pilot, yeah. South San Francisco, Daly City, San Mateo, and Redwood City.
Okay. Well, it looks like we have some questions coming in. I saw one in the chat that I think kind of fits what you were talking about a minute ago, Jen. Someone I recently know had an interaction with a man near Whole Foods. He seemed to, his chat turned bizarre with strange sayings. He followed her into Pete's. Who should we call in that situation? Calling the police can lead to unwanted results.
Yeah, currently, as we get all of these new, like 988 and other things in motion, if that person is posing a danger or frightening people, and you feel unsafe, certainly you should call 911. Once we have up and running, like the 988 number, that would be a perfect call for you to call 988, and then it can get routed to an outreach team that can then go out and check on the person. Does that help at all? I know it's like turning the Titanic. We're in the process right now of turning the Titanic, and we're like a quarter of the way turned. I don't think we're doing terribly. I don't think we're where we want to be yet, because that is a great question. And currently we don't have great solutions, but the teams that I have, that person will get to us and we will find resources. So if the person that was in the store made a call to 911, we will, now that we have CWCRT and Pert out there and people listening to the radio, we hear those calls and say, hey, that's a mental health call, let's look it up. Our teams also look up every single morning. Our Pert team looks up every 5150 that was in sheriff's jurisdiction the night before and either reaches out to the person. They touch every single one. They either reach out to the person, or they reach out to the person's family, or they reach out to the person's clinician, because we look up, do you already have a clinician? Are you already in a program? And in that case, we always tell the clinician what's happening, tell the psychiatrist what's happening, or reach out to the family.
Okay. Yeah. So the unfortunate thing is we still have to call 911, but I do want to add, law enforcement's been getting a lot of training. So you're liable to get an officer who's had the CIT, Crisis Intervention Team training out there. The approach probably will be different than it was a year ago. And with this person, they probably will be, engaging them in a different way, trying to find out who their treatment team is and getting them connected to any resources that they may have. And, I think in the interim, until these new systems can get in place, though, that's what we've got, right?
Right. Yeah, and well, yes. There is also a new, we are piloting a crisis email that goes directly currently just to me and my mental health supervisor. And I'm happy to put it in the chat. It is absolutely not for anything imminent, because it's a pilot and we're just checking out, right? Like, see how this works, how email type would work. So anything that's like that situation, that's not an email to the crisis team. Some other questions you might have, or, I'm happy to answer questions about how our teams work. And so you can send an email. I'm not going to promise that it'll be quick. We are really, really, really busy, but I will keep an eye on it, and definitely, things that come up can come to us.
Yeah, and we have another question related to Pert. So someone's asking, are there any differences between Pert and CWCRT?
There are quite a few differences between Pert and CWCRT. Pert, like I said, there's 2 clinicians, 2 detectives, and they ride together. So they're teams. They ride together every day, same detective, same clinician. They're sheriff's jurisdiction only. And because Pert's been doing it for longer, it's no longer a pilot. They've really got a groove of being able to both go to the crises calls, the 911 imminent type calls, or talk to the person the deputy on the phone and consult. We've gone out to with the crisis negotiation unit, but they also have figured out a way to carry a small short-term caseload, because you always have those people that maybe don't want any help at all, but that you're going to have to try a few times and maybe something will come up. So they will follow that person for a short amount of time because they are really busy, and they work really hard on connecting them to resources. CWCRT will get there, but since it's a pilot program and the clinician is not riding with the same deputy. So messaging is going to be very important about CWCRT, because it's whoever the deputy is on patrol that day. If they come across a person in mental health crisis, they're going to radio it in, and the dispatch is going to radio the clinician to head to scene, right? So that's a little different. The clinician will be working with different deputies all the time, which is also a great thing, because we're going to collaborate together. We're going to meet each other. We're going to build relationships with police, and they're going to, you get into a flow where you know which officers you're dealing with and things. So I think that's another avenue to try, but it is different.
Thank you. And another question related to this is, what is a clinician? Are they a psychiatrist, a licensed therapist, none, all?
Thank you for that question, because we just use the vernacular that we use and forget that not everyone knows. It is a licensed clinician. So that would be a licensed marriage and family therapist, a licensed psychiatric social worker.
Great. And then another Pert related question. So why has Pert never come when I called 911, as someone is asking?
Yeah, it depends what jurisdiction you're in. So if you're not in sheriff's jurisdiction, if you're not in sheriff's jurisdiction, you won't get sent Pert. Pert right now, we only have capacity to run, 5 days a week, business hours. So if it's an after hours call, you won't get Pert called out either. So that could be a couple of the reasons why.
Great, thank you. And then we have another question regarding CIT training. So someone is mentioning that in Foster City, the officers have completed this training, and they're wondering, when will this be done across other cities in San Mateo County?
Unfortunately, that is a stat question, not for me, but I can find out. I know there's, they're running all the time, but I don't have knowledge on how many departments are completed their whole department.
Great. And then we have a question regarding the 3 tiers of service. Are they available from 9 a.m. to 10 p.m. Monday through Friday? Someone to answer the call to those 3 tiers, and what are the jurisdiction areas?
So we're going to begin so when I say 3 tiers, let me clarify that's how I think of it in my mind. It's not really what we call it right now, but I just like the community to understand that there are different kinds of crises, right? Some can be handled on the phone, some need PD response, law enforcement response, some can just have a clinician response. So currently, one of our gaps is that all these teams, the latest SMART operates is 10 o'clock, and that's probably the latest team. I don't know if StarVista, Youth SOS, I think goes to 11.
We're actually, when fully implemented, which we are not, and will not be there for a while, but we'll be, our plan is to be 24/7 actually, with mobile crisis response all hours.
Yeah.
Great. And we have someone asking about a scenario. So outreach.
I feel like I'm defending my thesis now.
So this is the scenario they're presenting. Outreach clinicians first meeting with the family and identified patient. Patient has a history of assault and carrying a knife. Clinician wants to establish safety for the interview, but police are not willing to assist as it's currently a crisis. What's your advice with this? And will this new, team that comes out be willing to assist in a scenario such as this one?
I do have to say that I've been working with the law enforcement in San Mateo County for 5 years. I've worked my whole career with law enforcement. And if that scenario is something that had happened to you, it is, in my experience, a one-off. I can't imagine any of the officers or law enforcement agencies that I work with that would not come out to a call when you have a person with a knife threatening another person. So I'm not trying to be glib or anything like that, but in my experience in San Mateo County, we have some pretty excellent responses and officers out there that I don't believe I would get turned down for that call. And I'm really sorry if you did.
Thanks for the answer. And we have another question from a clinician. As a clinician who does 5150s at our county clinic and in the community, who sometimes has to call the police for backup, what suggestions do you have for situations when the police say they can't intervene in situations where the person refuses to say they can, where the person refuses to go to the hospital? 5150s are legal holds and we can't make a person go if they refuse. We used to be able to count on the police to enforce 5150, but now that has changed.
This is a tricky question, and we haven't completely figured out what we're going to do about the police response when it's a danger to self only, and there's no crime that has been committed. And it's a touchy subject, and it's a political subject, and it's all of those things. And I understand community concern, I understand law enforcement concern, I understand clinician concern, and all of those things. But let me say this is the topic of conversation that we are having at the commander's level, at law enforcement, other law enforcement level, my director's level, Louise's level, the director of all San Mateo Health. And we are actively working on this because yes, it's an issue in some cases. And if you really want to collaborate with your law enforcement, to have an ideal crisis system, everyone has got to collaborate, including law enforcement and community partners, right? And it's hard when you sometimes take one or two scenarios that have happened because there's some misinformation out there, both on the deputy side and on the clinician side, and then blow it up into something bigger. I am not, also again, not trying to be glib or minimize that we've had some issues with 5150s and getting, people that's the time when they get aggressive. Once you say I'm in a 5150, right? I'm taking you involuntarily to the hospital. So it's a work in progress. Again, like I said, it's a work in progress. And I hope that the community can be patient and, love all the suggestions and the ideas and even the issues that you may have had. And we just have to keep working on it and keep talking about it until we meet in a place where the crisis team and where we're all working together in crises. And I know that's not that satisfying of an answer. Believe me. It's the Titanic.
Yeah, we have someone asking, can you provide examples of what the crisis email can be used for? And also what is that email?
Oh yeah, I'll put it in the chat. I'll remember to put it in the chat. Yes, for now, because I'm piloting it, I am actually, and because of these questions around, what's happening in the county and the community, and I had this happen to me, is it happening everywhere? I would love to hear, questions you have about the teams. If you need resources and you don't know where to go, I'm happy to have you email for that kind of thing. Any issues, good stories are wonderful as well. We love to hear those good experiences that you've had. suggestions that you have for how you would like to see it roll out. You know, anything really that pertains to crisis and what's going on in San Mateo County. I can't answer like legislative. I'm not a legislative or policy. I know quite a bit about 988 now, but you know, I'm happy to help, you know, especially families who need support. You know, I have had my own experiences with children with mental illness, and just being able to email someone and say, hey, this is what's going on. What resource can I call? You know, who do you know that can help with this disorder or whatever it is? Those are my favorite ones to get, because we have those answers. We just don't have it all in one place and also easily accessible to the community yet.
So a couple of questions came in about the clinicians. May asked if the job listing was available, and we provided that link. So anybody who's interested in that job, you know, if you're out there and you're a clinician, the qualifications are pretty stringent. I mean, you're looking for some good people, and I hope that you can find them. Evan Milburn asked, are any internships available?
Zena, do you want to answer? I don't know if StarVista has internships.
Is that particular to the CWCRT team or just in general?
Well, you know what? Why don't you go for both?
Well, I have to say, and William can speak to this well, we're always looking for volunteers at the crisis line. And we do, you know, just in general have openings as well. I wouldn't be able to speak as much to the CWCRT, but perhaps we can follow up and find an answer for that. William, if it's okay if I backtrack just 1 second, because I did just want to add in the question around, you know, being a provider or service and sort of being able to get direction around crisis services in the county. I think, you know, the crisis line is also a really great resource for that. And because the crisis center, it does, you know, have a pretty good relationship with Jen, and we stay connected. And as she mentioned, she sort of oversees the implementation of the Youth SOS team as well. Oftentimes what's sort of been happening on our end is that when we, you know, receive general, you know, questions around, you know, the particular service, or if there's themes about sort of what's, you know, happening on the line, of course, no specifics, and we do everything to maintain confidentiality, but just highlights of it, then it gives us a little bit of room to try to understand what information does need to be put out there more or clarified to others. And so I just want to really encourage anyone to also use the crisis line as a resource for that as well.
And that number is?
A little bit to that. On the top of my team's list is an internship program for a couple of reasons. You know, BHRS is very invested in equity and inclusivity and diversity, A, and B, getting more people interested in the crisis field, right? Because I've been doing this for so long, and it's really hard to come by people who want to do it. So that is on one of the things on the top of my list. And then, you know, every now and then we do get postings for a not licensed. So you have the licensed clinician, and then you have one that's not licensed but has graduated and they need hours. So, you know, we're also looking into that sort of a program, so you can come and be supervised by one of my team and get hours. Not in progress yet, but it definitely, I think we really need to pull more people, more diversity into this field for sure.
Okay. Well, I think Brooke's been too quiet for too long. So here's a question. Which program can be called, this is from Mary, which program can be called for a foster city crisis, say for a mom having a crisis with small kiddos?
Our crisis line is a great resource for that, especially if the crisis is with the kiddos. The Youth SOS team would be a perfect use for the Youth SOS team. We are serving 0 to 25. So, and I think I'm speaking with like-minded individuals and people who are connected to this work and this topic in general. But you know, we don't have age like minimums. No, it's 0. We understand that young kids still have thoughts of suicide, still are very serious about it, and have escalating mental health symptoms that, you know, maybe adults kind of go, oh, they're too little, they don't know what they're talking about, or they're just acting out, right? Like a lot of times it's stemming from mental health, and that is something that our SOS team will definitely be able to go out and assist in.
Do you ever help children in schools, perhaps?
Yes, all the time. So prior to being the program coordinator, I was the mental health clinician for our crisis center, and part of my role was to do consultations and assessments in our school districts. So I did that for 3 years until now when I'm taking this new team on. But yeah, we would go out. I've done assessments on someone as little as 4 years old. So we really try to train and will train our clinicians that join our team. We are also hiring as well. So if you are looking for something a little less intense, because we don't have the police component to it, also feel free to look at our job listings for Youth SOS. But yeah, we hope to train our Youth SOS clinicians in meeting the person where they're at, whatever their development is. If they're a young child, or if they're a teenager or a young adult, we will equip them with the tools to handle that.
Wow. So if you're contacted by a school administrator, you would actually go out and meet with a child to assess them for suicide and work with them to get resources. And that's amazing.
Absolutely. We would go out and we would do an assessment. Sometimes it's just a school provider who's already done an incredible assessment of their own, and they just need a little reassurance on what the best next steps are to take, or maybe they kind of want consultation around like, okay, I know that looking at my assessment, they definitely, need to be hospitalized, but what do I do with the family? How do I inform them? How do I go about having those communications? So we don't just do the assessment. We also, again, like to look at the entire system that's going to be impacted and how to make sure that we're handling that in the most trauma-informed way that we can.
Wow. Does the family get charged for that?
No. Thank you for prompting me with such great questions, William. No, our services are free of charge, any of them, except for, if you're like LinkedIn, we might charge you for a presentation or something, but no, for our community members, it's free.
Incredible.
I just want to add too, in addition, and Jen kind of talked about this with the Pert team, but the team that used to be only Brooke also had a small caseload. And so it wasn't just sort of like a one-time meet and, let's discuss or have a consultation. There's ongoing follow-up and a connection to services. And then as the Youth SOS team expands, and we'll continue to do the same there. And I mentioned this sort of at the start, but just want to re-mention it again. And thank you, Allie, who's on the call and added this information. But we do also have team chat and text line crisis support for any teen 13 and plus. We won't turn anyone away for their age. And so she added the link to SanMateoCrisis.org, which has all of our information and access to the chat there, and then also has the text line number too.
Wow. We had another question that kind of got buried. Are the 3 programs being discussed similar to the CAHOOTS model?
Yes, similar. Not exactly the same, but similar. The CAHOOTS model also has tiers. Like CAHOOTS doesn't go out if it's a 911 person that is suspected of having a weapon, or they're not familiar with the person. They might come out in stage, but it would not be the first knock. It's still PD, that's the law enforcement, that is the first knock, even with CAHOOTS. But what they do have is a very robust service connect team, and then a behavioral health response teams that they'll go back out to that person, after it's all safe and all the things, and they get to know them a little bit, and they'll keep going back to that person. And then so do the handoff to the referral system that they have.
Wow.
But they use medics too, excuse me. They use a medic and a clinician.
Yeah, and I've heard that, we read a lot about CAHOOTS, and it kind of sounds like it's presented as a full-blown solution, but I've actually heard that if they arrive and the person has a weapon, they're calling 911 just like everybody
100%.
else.
Yes, 100%. Mm-hmm.
Yeah.
It is put out there, just, with everything going on, it's a little bit of a misnomer. they're a great team, not saying that they're not. Absolutely fantastic how they resource and hook people out, and they have so many. But no, they're still using 911 for you know, people you don't know, people with weapons, people you're not sure of.
Okay. Chris has pointed out that Youth SOS Fund program was funded by MHSA, Mental Health Services Act money. And so, yeah, it just delights me to see MHSA money used for things like that. So now we have, is the 988 number working now? Why is it not being advertised? Are all counties waiting until July 22?
So Jen, you're smiling, you might know more about this, but as far as I understand around 988, there was a switch with telephone providers, and the number is functioning and working technically. And so, yeah, if you do call now, ideally, you're going to be routed to us. It's just more that our full implementation and plan for it, we are here, and if we advertised at like a really large level, the concern would just be around capacity and people being able to respond to that much of an increase in call volume. So yes, it is technically working. I have heard that, not so much in our county, but from other counties, that people are calling, and we are, you know, we're ready and waiting. We have staff, we have people available, and we're just sort of following the lead of kind of this like official implementation, July 2022.
Thanks. So Kay is asking about the Cahoots program and whether it's private or part of the county. Cahoots is in Northern Oregon, I believe. So they're kind of just another model that's going on somewhere else that we're looking at, not something that can be accessed in San Mateo County.
But they're not private, they're a county program.
We have another question regarding Pert. Someone's asking for clarification on where, please clarify where the sheriff has jurisdiction and access to Pert and other county services, and where they don't, as in local police departments.
I knew someone was going to ask me that. I wonder if Jess is on this call right now going, ha, ha, ha. So, okay, sheriff's jurisdiction. Everybody's going to have to help me. Half Moon Bay and Millbrae and
San Carlos.
Obviously that's where our substation is. All unincorporated areas of San Mateo County.
I see Moss Beach.
And Moss Beach.
Yeah. Oh, look at Chris. Thank you, Chris. Chris is my go-to jurisdiction guy. So he just put it in the chat.
So Coast Side, San Carlos, Millbrae, North Fair Oaks, unincorporated SMC. Thank you.
Myself, it's because I have too much information in my brain, so I have to let some go. So that would be the jurisdiction area.
Now, kind of circling back, we had a question earlier. Can we get a description of the 3 tiers from Jen Bassler? How are the tiers as you kind of envision them?
I wish I had my roadmap right in front of me because I have it bookmarked, but the paper that William was talking about at the beginning was written in 2021, recently came out by Advanced Psychiatric Committee. Is it that Advanced Psychiatric Committee? Anyway, they have the sort of same tiers that the way that I think of it. Okay, so a tier 1 is you need a 911 response. You need law enforcement there. There's weapons, there's a crime being committed, there's somebody else in danger, someone else is in the house, somebody else is in the way of this person. That is a tier 1. Okay, so for a tier 2 response, which is more like what Cahoots, SMART does, sometimes there'll be law enforcement, but not always. Sometimes law enforcement will be on scene, but the smart people will do the assessment and say, you know, it's okay, the person's gonna go, you guys can leave scene. So that would be a tier 2, which can, you know, could go either way. A tier 3 is a situation where I would send, I've sent clinicians out to, like, say someone who has a mental illness and is also a hoarder, and, you know, we're pretty certain this is a safe situation. They always have access to call 911 right away, but they go and they deal and talk to them, and they'll do therapy in the field if necessary, try to find them resources, and then hand them off to someone else. So that would be your tier 3. Kind of like a connection team would be the tier 3. And you know, the stats, if anybody cares, you know, wants to hear about stats, so I ran a little today, so they're not perfect at the moment, but for 2020, in 2020, there were about 725 Pert calls, so that is in our data. And, you know, of those calls, maybe 8 were a tier 1 call that law enforcement absolutely had to be there and had to stay. So it's a very low number, knock on wood.
Yeah, now as I understand the Southern Arizona model, and if I get this wrong, don't inundate me with emails, but they basically have a 5-tier system that's kind of structured the opposite way. Tier 1 is the call comes into 988 and the 988 operator can handle it. It gets handled by phone. Tier 2 is that there's some combination of low-level workers, you know, maybe a peer worker and a social worker go out and look at the person, assess them, talk to them, see if they can resolve it. Tier 3 then is more like a social worker and a clinician. Tier 4 kind of reflects what this pilot is doing, in which you'd have a co-response of law enforcement and a clinician. And then tier 5 is, you know, there's imminent danger and law enforcement's going to have to handle it. And so, you know, I think that these are getting defined in different ways, but the concept is the same, in that you're triaging the calls to try and handle them at the lowest possible level and to try and send out, you know, the least invasive type response in terms of how you deal with it. And, you know, unfortunately and quite clinically, I think you're trying to respond to these things in the least expensive way too, you know. And so it's, yeah, it's a model. And I think we're going to see it come into play in one way or another. And, you know, I think a lot of what we're talking about tonight is that we just don't really have what in the way I just described it, that tier 2 and that tier 3 in San Mateo County right now.
And Claudia's asking, is there a type of chart that exists that explains the difference between each program and which one is best to call?
Yes and no. To get to some of our programs that we have, so to get to Pert, you really do have to call 911. To get to CWCRT, you do have to call 911. Now for the other teams that I have that have very limited capacity right now to go out to any like lower level, not as imminent of a crisis calls, you would probably have to call, I mean, it's going to have to be either a new crisis line number, or StarVista is probably your crisis. That would be a good time for them to call you, right? So yeah, the difficulty with ours is that the crisis and outreach team also have specific jobs they do. Okay, so they're part of my crisis and outreach. So one of my clinicians will work for assisted outpatient treatment program, and that's a specific population of the seriously mentally ill that are hardest to engage. Now, if they're not on a call at the time and I get a tier 2 call that's out in the community, I would call that clinician up and say, do you have the bandwidth? Then can you please go to this call?
Great.
You know, I kind of wanted to circle back because I'm not sure everybody can see the questions and answers, you know, because maybe on the phone or whatever. And, you know, Evan asked, what's your definition for youth, Miss Andriani? And the answer was under the age of 25. So when we're talking about youth, we're talking about what I think is called TAY, transitional age youth, as opposed to minors, which is people under 18 years old. So I think it's great that the services extend to that little older age. And then Kevin Lopez asked, how are you guys planning to promote these services to youth in the community that might not have access to resources? And Brooke answered that in writing, so I'm going to ask her to read it.
Oh, William, but I love hearing your voice. You can read it out loud. I first said great question, because I think that that's really a wonderful question and part of our planning for these programs. And one thing that's wonderful is the Crisis Center is already very engaged in our community. We do a lot of outreach and engagement specifically with the schools. We have done presentations. pretty sure at almost every single school, public that is, some privates too, but we've done presentations at almost every single school about mental health, suicide prevention, as well as talking about our services. And considering with the Youth SOS team, being that literally the youth in crisis themselves can give us a call and request our support, we think that that's a great place to start. We also, have already made it part of one of the roles. So part of our family partners role will be to go out at community events and into the community and promote our services, explain what we do and how we can respond. And then, even more so than that, we are part of a larger agency, StarVista, and within our agency, we do have a development and marketing team. And we're working really hard with them to kind of figure out a way to promote our new services and kind of our enhanced services that we already have had and kind of engage our community partners that way as well. But thank you, Kevin. That was a great question.
And a question from Claudia kind of ties into that. Regarding the Youth SOS team, would StarVista be willing to present to the family partners so they can share the resource with families? And I'm not sure exactly what family partners is. So if Jen or someone could clarify that, or Claudia, who asked the question.
I think I responded to that. I just want to add one other thing to what Brooke said, which is that we do try really hard to find ways to do outreach for all crisis center services, not just mobile crisis, because we know kind of the traditional channels we're well plugged into. But I just wanted to bring up a story from a former employee last year that at the start of the pandemic, got a bunch of flyers, printed them out, and then brought them to like a local food bank. And so we're trying really hard just to make sure we're kind of in all places. And this person also was really good at flyering at different events or just literally putting posters wherever they could. So we do try to just make sure that our information is out there sort of in a accessible way, but in all the other creative ways that we can try to as well. And then for presentations, yeah, we're happy to provide presentations to anyone. So I know that there's a group of family partners in the county, and Claudia, I can message you about setting up a time to offer that presentation.
Now we're getting warm. Thank you, anonymous attendee. When someone is at a crisis home, Serenity House, for example, what is the next step for patients to keep them out of the hospital and to avoid them ending up homeless when they cannot return to their family home after a mental health crisis? Looking to better understand in this transition period, available options after crisis home stay has ended for a patient.
So Serenity House is a short-term placement for people who don't know that may come out of PES. They don't have to, they can be referred in other ways, but they stay at Serenity House where they have programming and psychiatrists. And they also have a connection team that resources them to the appropriate, probably BHRS service upon their release, setting up appointments, maybe getting some sort of group, or we have housing supports through BHRS as well. And that's not my wheelhouse to know how to access. You'll have to invite Mariana next time. But their housing resources are there through BHRS. And, we just try to keep them connected. It's not always successful, but it is, it's sort of like a discharge from a hospital where they, these are the pills you need to take. Here's your prescriptions. Here's who you need to see next. Here's your psychiatry appointment, things like that.
In terms of Serenity House, somebody can go there voluntarily as opposed to going to the hospital, right?
Yes and no. If they are deemed 5150able, they cannot go to Serenity House. They have to attend the hospital first. So if they're so such a danger to them, such an imminent threat to themselves or to others, or just so gravely disabled that they can't care for themselves, the Serenity House would take them over to PES to be evaluated first. If that is not the case, then yes, they can.
Now, I've also heard a rumor that Serenity House won't take anybody who identifies as dual diagnosis, having both mental health and drug and alcohol problems.
I have not heard that rumor.
Okay. But they're definitely not going to take anybody who's high or drunk.
No, no. And the reason, for that too, is that it's very triggering for the people that are staying there, that are trying to get stable. So that's when you would go to like First Chance to sort of sober up.
Yeah. All right. Anne has hit us from both sides, so she must really want this answered. We know what the sheriff's department is doing. What role do local police departments play in the mix?
So that's the CWCRT program. So that's the pilot program. Now, local police departments that are not part of the pilot program are, we didn't want to start something huge until we, as you go along, when you're building these programs, things come up and different things happen and we figure it out. And so not all cities wanted to participate until they see what's going on with the CWCRT program first. So if you live outside of Pert and you live outside of CWCRT jurisdiction, then the way that you used to do it, still the way you do it. You call 911, you ask for a CIT trained officer, and that's the route that you'll go for now.
Okay. And, I would add to that, there are a lot of different jurisdictions in the county and different cities, and police procedures are not going to necessarily be the same everywhere, and this pilot program is in these 4 cities. And as we noticed earlier, those aren't the cities that are covered by the sheriff's department. But then the sheriff's department is doing the crisis intervention team training and trying to get law enforcement in all the cities trained in that discipline. So I think that will bring some consistency to it, but you could see different things in different cities. And that's just kind of the reality of the situation.
Yeah, correct.
Kay Brown asks, is StarVista primarily attend to youth under 25, or do they also assist adults?
I mean, so you have me here who's talking about our Youth SOS team, so I could see why it might seem that our programs are only for youth, but that is definitely not the case. We have a ton of different services for, our tagline for our agency is helping all ages and stages. And that is really true. There are a ton of programs at StarVista that service all different ages. At the Crisis Center, our hotline is one that services everyone from, however old you are when you can pick up a phone and call somewhere, until the late 90s. I think we've had folks call us in their 90s. So while the Youth SOS team is very youth focused and youth driven, a lot of our services are for adults or families, and we do have other youth programs with StarVista as well. But great question.
Okay. Yeah, and there's the StarVista Crisis Counseling Center, which obviously takes adults. The Pride Center is for all ages. The mandatory offender programs, I think, are primarily adult.
Yeah, sorry, William, to interrupt you. And our counseling center does all types of therapy as well. So it does individual therapy, it does family therapy, it does couples counseling. So really, all different types of folks can utilize our counseling services.
We have another great question regarding if there's any plan to incorporate peer workers into the new emergency crisis or emergency response models.
100%, absolutely. I think it's one of the most important elements of the entire crisis system is peer support.
Yeah, and with all this peer workforce grant money out there, you might be able to get some stuff funded too by doing that.
And Claudia's on the call, right? I won't call you out, Claudia.
Well, she was asking you questions, so I think turnabout's fair play.
Yeah, because there's a peer certification now in the state, which is really cool.
Okay. All right. Well, we're a little ahead of schedule, but at this point, I would like to ask our wonderful chair of our Fund Development Committee, Kate, to come on and talk a little bit about what NAMI is doing for the walk, because as I was kind of facetiously asking Brooke about StarVista's services being free, the stuff that NAMI is doing is free also. And, you know, we have support groups for parents, for peers, we have for families, we have classes, we do a lot of stuff. And it's great that in an industry where it just seems like demand exceeds supply, that we're in a situation here to be giving these services away. But we have to find ways to support that. And I see Kate now, so I'll turn it over to you.
I'm trying to choose my background, but it's not happening. Anyway, you'll have my background of my office. Hi, everybody. I'm Kate Phillips. I am a new NAMI board member. I'm an author and academic by profession. And I also think it's important to say I am in remission from bipolar 2 disorder. This year we're doing I'm helping to head up our NAMI walk, which is going to be on October 9th. And we're doing it a little bit differently, that you can do it either in person or virtually. I have 4 kind of main things that I think this walk serves. The first is awareness of NAMI and what we have available and how we exist. The second is to fight mental health stigma. You know, the reason that I said that about myself is that I have found lately people can be surprised when I'll say that, but in general, people are like often very grateful and will open up about their own stories if they know there's somebody else who's comfortable talking about it and not afraid. So by going out with the shirt on and actually being in the community and showing you care about mental illness and mental health can mean a lot to other people and do a lot to fight stigma, as can if you participate virtually and you put your photo on social media and link to the site. That's another way of fighting stigma and raising awareness. So those are in some ways the most important goals. Another goal is the idea of walking or doing a physical activity is good for our own mental health. So there's that aspect. And then finally, you know, for NAMI, our big thing is that this is our main fundraiser for the year. We have so much more we could be doing if we had more funding in just all areas. And we have a goal for this walk of raising $100,000, and we're almost halfway there, I'm proud to say. So we're doing pretty well, but we still have at least $50,000 to go. We have 4 weeks to go. So to tell you how you can participate, if you go onto our website, you'll see that you can go on to where it says NAMI Walks, and you could either just choose to participate by yourself, or you could make a team, or you can join a team. I have a team, Christina has a team, Twyla has a team. You could contact Christina, her email address is on the initial walk page. And you could ask her, if you want to join an actual team that's going to walk, you could ask her you could tell her where you want to walk and ask where you might do that with someone else. Otherwise, you could form your own team, which can be even better, because in my mind, if we can spread out around the county and walk in different places, and here's a shirt, a sample shirt that we have, but this year's shirt will also have, on the back some of our sponsors, which we're proud to say include Facebook this year. So we got our first large corporate donor for NAMI San Mateo County. And in my mind, if we can have different groups, you know, there's something to be said for when we used to have one huge walk, but now that we're splitting up with COVID, there's something to be said for walking in all different parts of the county, wherever you and your friends might want to walk. And again, wearing those shirts or carrying a sign that says who you are. So I kind of, my personal ask for you guys would be, if everybody who's on this call who really cares about mental illness and mental health could just, I was thinking of like a helping handful, could just ask one handful, like 5 people or 5 friends, to either join you in a team or, you know, go on to Nami and think about joining our team. Really, like I said, not just to raise funds for us, which we do very much need, but also to fight stigma and raise awareness. And if you get very energetic and you want to help us in the next month before our walk, we also have we have flyers like this that you could put in your workplace if you're a clinician. We have some people already doing that. Or if you have a favorite coffee shop that has one of those boards where you can stick notices, something like that. It may or may not get us a walker or a donation, but it definitely people will see it, and that will help us. And we also have materials if you happen to know people who might like to sponsor our event. So like if you're in an organization that might like to, you could ask Christina to give you our packet. We have like our impact report and our sponsorship materials. So that's about it. We would love to have, like I said, as many of you and your friends participate as possible, because, you know, if we did have everybody here on this call doing 5 people, we'd have like 600 people, which would be huge in San Mateo County, right? So please join us and join my team if you want. And thanks, you guys.
Thank you so much, Kate. That was wonderful. And yeah, it's very important. So in the interest of leaving no stone unturned or no feather unruffled, you know, our panelists are still here and will stay for a few more minutes, I mean, or longer. If anybody has any questions or concerns or anything else that they want to raise about this subject, we'll take our best shot at answering it. We'll tap into the audience if they can help us. Fire away. And if not, I'm sure the A's are still on. Okay, unless there's anything else for the good of the order, I will turn it back over to Twyla.
We do have one question coming in.
All right, I hope it's a good one.
Yeah, so it is, why not a 24/7 pilot program?
That is a staffing issue, really. It comes down to how we're, you know, discovering brand new ways, working with StarVista too for Youth SOS to try and entice clinicians to come to San Mateo County. And that's just honestly the reason. 988 will require us to be 24/7 by 2022, correct? So that will be coming.
You know, and that's kind of an interesting question too about 988 and these mandates that are coming with it. Mm-hmm. You know, it involves a lot more than just answering the phone.
Yeah.
And so, you know, has that been thought through, how it's going to be, the other aspects of that mandate are going to be implemented?
Oh, yes, we're working on that already. Yeah. And luckily they moved some of them to 2025, because some of them, you know, some counties were just like, just can't do that in 2 years, a year.
Yeah.
Yeah.
And just as a ballpark, when do we think it'll come up in San Mateo?
The 24/7 piece?
Yeah.
The 24/7 piece has to be there by the 988, when the 988 goes live in 2022.
In 2022.
And then there's other pieces that we don't have, you know, that are going to probably be around 2025, but more resources, more kind of urgent, let's say, just for an example, I don't know if this is one of the things, but urgent walk-in mental health places or more. It's going to require us to put more of a focus on mental illness as a health issue, just like physical illnesses.
We have a question. What is the name of a dual diagnosis center for patients with mental illness and a drug or alcohol problem?
Off the top of my head?
Well, one question would be, does this person have insurance? because if they
Correct,
have,
yeah.
yeah, if they're with Kaiser or they're with Anthem or whatever, they're probably going to have to go through their own insurance.
They will.
If not, then we would probably say, you know, if they're on Medi-Cal, call that access line, and hopefully they would get referred to maybe Project 90 or one of the other Kaminar programs.
Mm-hmm. Yeah.
William, I keep doing this too, but I just want to backtrack to the 988 question and the rollout. So the two things that you know, as I mentioned, we're sort of in this planning phase with a bunch of other regional crisis centers and around the state. And the information that we've received basically is that, you know, for certain, the outreach and the actual utilization of the number 988 and the transfer from 18, you know, 273 talk to 988 will happen July 2022. That there should be some form of like 24/7 mobile crisis response, but there's some nuances to that. And then the other piece is that 988 should also be a texting line. So that I think that's where a really big piece is focused on, at least like for the crisis centers, is just what that model is actually going to look like. Is it sort of saying every center that responds to calls also has the text, or is it sort of it all goes to one hub and then somehow is redirected? But I think there's a lot more focus there. And then you know, the bill was passed and it was very, very ambitious, and so I know that it's up for review and kind of will continue to be modified over time. It was huge that we got funding at least to try to start implementing something or get those like early pieces figured out. So I just imagine that it'll, you know, slowly but surely come out, and the push for, you know, July 2022, like I said, is really going to be about the number itself and then texting. And then third to that is crisis response.
Yeah. Oh, here's a good one. Jeffrey would like to know, do you have data on how many 911 calls are made prior to call turning into a 5150 situation for an individual?
I do not. I probably have some data related to Pert, but of course, CWCRT has not. But what I didn't mention, which I forgot to mention, was we working with CWCRT is a organization called the Gardner Center, who's going to analyze the data, you know, take out any of the HIPAA information or anything like that, so that we can get a good grasp on when the calls are coming in, what are the best times to staff. All of those things are going to be analyzed through this program.
Okay. But you do have some data about the number of calls that actually end up turning into, you know, the number of calls about mental health emergencies that end up being handled without any issues or people being arrested or taken away or hospitalized. Could you give us a little insight into that?
Well, I would have to look because there's a lot. I mean, we've been tracking data in Pert, but so I didn't look that piece up. When I looked up the 726 calls, just sheriff's jurisdiction last year, that's a mixture of family calling, referrals, and 911 and 5150s.
All right, Jen, while you have the floor, what can the county do to help us lobby to enforce parity with mental health insurance?
Good question. Does anybody want to take on that question? I don't, you know, that's a tough question for me to answer because my focus is so much on, you know, the program and the rollouts of the pilots and the crisis response things that I don't know that I can answer that. I think William could answer that question better than I can, as a matter of fact.
Well, you know, we keep stirring the pot around it. You know, it is interesting because all those laws were passed around mental health parity, 2009 or so. Yeah. And yet they just seem to always find loopholes and ways around it. And yeah, it's definitely something that needs to be taken on from an advocacy standpoint. I wish I had the answer. How can one schedule counseling for a single mom with family at StarVista?
I am looking up the intake number to put in the chat for you, Mary. Just give me a second.
And there we go. Okay. I don't see any more questions coming in. So we are at 8:30. Let's see. Why have the fire department EMTs largely been left out of the mobile crisis response equation?
Well, I mean, I don't think that they've been left out as much as San Mateo County has just always done things the way that they've done things, and everything has gone fairly smoothly. It's with the changes in the world, I really feel like this is a tipping point, and they are definitely no longer being left out. We, in all the meetings I was talking before about, you know, who needs to be included and how we need to do this, it's including the high level fire, EMS, dispatch, like all of us are at the table.
Yeah, because, you know, now that that question comes in, I hadn't really thought about the ripple effect that's going to happen across all the people who are involved in mental health emergency responses.
Correct, yeah. Mm-hmm.
Okay, how can a young, brilliant college student help or get involved with NAMI? I know a guy. I would say start by having him call 638-0800 during business hours, and he will get connected to the warm line. And maybe if he likes what he hears, he could actually be on that warm line, or any of a number of other things. But, you know, I will say most NAMI trainings, most NAMI programs are a result of trainings that were developed at the national level. So everybody who's doing something at NAMI, like training peer-to-peer or training family-to-family or acting as a connections facilitator, has had to go through these trainings that come down from the national level and pledge fidelity to them. So, you know, whatever it is, there are ways to get involved, and it's great learning experiences, but there's a little work to put in on the front end. All right, I guess I will turn it back over to Twyla.
Okay, thank you, William, Zena, Jen, Brooke, Christina, Kate. Well done. I'm just gonna close with just saying, you know, this is just the start of the conversation. As we've heard, 988 isn't gonna be fully implemented until next year in July of 2022. And there is still a lot of work to do. So let us know if you want to join our CIT task force group, because there is a lot more that needs to be done. So thank you all for attending. And as we've said in the chat, the recording of this meeting will be on our website, but what we'll do is, in addition to sending out an email blast to those in our database, we will send it out to all the people that have registered for this webinar, right? Thank you, good night.
Thank you very much, everyone, for coming. Really appreciate it. And the community support is just wonderful.
Bye-bye.